Good afternoon and welcome to today's webinar. I'm Ngozi Lawal, Project Director of the Prenatal to 3 initiative here at the Center of the Study of Social Policy, also known as CSSP, and today's conversation is focused on early relational health, presented by Dr. David Willis, a Senior Fellow at CSSP. Our goal today is to provide you with an overview of early relational health, also called ERH, and to help you think about ways to promote it in your own work. Just for the purposes of keeping the communications clear, we've placed all of the participants on mute, but we welcome your thoughts and your questions and reflections. So during the webinar, please feel free to type in your questions or your thoughts, and our goal is to read those during the Q&A period. Or when we get to the Q&A period, you can click the feature that allows you to raise your hand, and we will unmute you, and you can go ahead and ask your question. So we're really excited that you're here, and we'll go ahead and turn it over to Dr. David Willis.
Thank you, Ngozi. Are we set? People hearing me?
Yes, we can. Go ahead, please.
That's great. Well, good afternoon and good morning to all that are attending. I'm thrilled that you're interested in this topic that we're going to talk about today. I also want to thank the Perigee Fund for helping to support the early relational health work that we're advancing here at the Center of Social Policy within child health and communities. And so I'm thrilled to be able to have this chance to talk with you about this broadening concept. I'm a developmental behavioral pediatrician by training. I like to think of myself as an infant mental health specialist in pediatric clothing. I was a clinician for 35 years in Oregon. Spent a lot of time working with families, especially young families that had brought to us the challenges of their young children. And all parents are really eager to see that their young children do well developmentally. They're all interested in their children being happy. They're all interested in hoping that their children's future are better and stronger than their own. And yet all parents need support and all parents think about the challenges in front of them and seek information. It's within that vein that I've had a long journey of trying to understand how do we maximize development. Back in my early years of my clinical work, we started seeing increasing numbers of children, quote, kicked out of childcare, unquote. That really raised for me a big question about why is it that young children are being challenged? Why is it that their development creates difficulties in such a way that we start noticing symptoms and observations, and then over time start seeing the difficulties they have behaviorally or then into mental health-based issues? And it's always raised the question of, for me as a developmentalist, what are the early factors that we can bring forward to help build capacity of young children? And what are the forces and challenges that disrupt development? So as you see here from our dear friend Neil Halfon, the opportunity to build ideal child development is in front of us. And how do we, in a lifespan and a life course sense, move upstream in terms of building human capacity, human development, and to establish a good start from the beginning. All of that, of course, is focused on the core story of child development. As we all know, over the years, early experiences are built into the architecture of the brain. The Neurons and Neighborhood report that came out almost a decade and a half ago talked about the importance of communities surrounding families in the support early of building human capacity. That brain development captured the imagination of this country in the 90s, and the neuroscience has really been growing and building, all focused on that children develop in the environment of relationships. That concept of what are these relationships and what are in fact the patterns in relationship that build health or the vulnerabilities has been something I've spent a lot of time thinking about with others and studying. And that's, again, the frame that we're going to be focusing on. As we know, cognitive, emotional, and social capacities are inextricably intertwined, and they are outcomes that happen as a result of all relational experiences of all caregivers. We also know from the great work of the National Council of the Developing Child at Harvard that toxic stress or adversity disrupts human development, but there's a buffering effect, again, of relationships. Hence, we also know that there's a plasticity in human development, and we know out of the field of psychology, infant mental health, therapies, that strong supports early through relationally mediated interventions can heal and build recovery processes in the face of adversity. Again, pushing on human development occurs in the context of relationships. Because I'm a pediatrician, because I ended up having time at HRSA, running the Division of Home Visiting and Early Childhood Systems, and thereby exposed to the growing policy interest around population health, it certainly had me begin to think about population level issues. And as we all know, 60 to 70% of children can be considered to be healthy and ready to learn. But we have large numbers of children, despite children with special healthcare needs, but those that have behavioral, developmental, and learning challenges, those numbers, in fact, are staggering. And if we look at the current status of the children in our nation and the challenges that they face, more than nearly 2/3 face some risk factors for poor health and social or developmental outcomes in their contexts. We know that poverty is a significant disruptor of human development. We know that these processes of development start incredibly early, and that there are disparities that can evolve by the earliest experiences, hence that 30 million word gap concept. We're also witnessing that, unfortunately, a number of children end up with later diagnosable mental health or behavioral disturbances. And as the movement around kindergarten readiness elevates across the nation, in this, even as some data in many states that have measurements of kindergarten readiness, we're seeing 40 to 60% of young kids as they come into school having weaknesses of quote, kindergarten readiness, unquote. Most often, it's in the social emotional skill area. And as a developmentalist, I've really struggled with understanding what is social emotional development? How do you measure it? And what does it look like? And what are we talking about? And even recently, I've heard that many of my colleagues in pediatrics and even in communities, although deeply focused on social emotional development, when you come down to defining it and measuring it, it becomes increasingly difficult. The other area that has really driven my thinking around this work is about, unfortunately, the continued um, increasing prevalence of, quote, mental health disorders, unquote. There's not been enough dialogue, in my opinion, about preventative mental health, but we know the drivers that happen so very early that disrupt mind-brain development, be that trauma, ACEs, neglect, insecure attachment, primal mental illness, genetics, or the community context of adversity. All of these, unfortunately, disrupt the development of healthy mind-brain systems. And RWJ a couple of years ago reported that the lifetime prevalence among 18-year-olds can be up, for any mental health disorder, can be up to 51%. Our children are struggling in their development, in their mind and their brain skills, and in their self-regulation and their emotional lives. We're seeing the increased rate of suicide. We're seeing increasing rates of anxiety and depression. These are troublesome, and we know that they point to many of the drivers that occur in early childhood space. We also know that the disparities in this school readiness activity begins incredibly early. And in 2016, Dr. Nelson reported on a reanalysis of the longitudinal data in the early childhood learning longitudinal study about the 4 variables that actually predicted academic and behavioral risk, which were, as we know, parent educational level, insufficient reading at home, which is really about stimulating language and development and interactions, about food insecurity, which is code for poverty and stress, and then poor mental health, which often is about maternal depression and trauma. These variables start showing, even at age 2, disruptions to healthy developmental patterns. These are not the children that are seen in Part C or in early intervention, but still are in their developmental course. Even by age 2, we're starting to see the disruptions of their developmental well-being that end up being at school not ready. Just this last month, there was also a report that talked about, as we all know, the exposure to poverty in early childhood, and it has direct impact on early childhood outcomes. And again, an administrative data analysis in Canada over almost a 9-year period up to age 7 looked at outcomes that were noted in the administrative data related to the place living and the poverty level. And strikingly, children born into poverty had greater odds of not being ready for school or higher rates of these outcomes than those not born in poverty. We know that. But they also demonstrated that for those born in neighborhood poverty, the odds of school readiness were higher only if the children had not moved by age 2. What they concluded was that the level of poverty in the household or in the neighborhood and its duration then modify the relationships between poverty and childhood outcomes. This is a very positive statement because it means that if we address the context around young children and help them counter the adversities of poverty, either by the improvement of their poverty rate or supports around them, we can see improvement of outcomes over time. I think that that's really meaningful as we're moving forward in our discovery work in our communities. The other work that's really striking in this space about how do you build well-being is our growing awareness of the 2-gen continuum, and that is that whatever we do to help support parents likewise is important in the support of children, and vice versa. When we're efforts to support children, we should simultaneously be thinking of their family. This focus 2-generationally is looking at the relational context and how families surrounding young children, of course, no matter what our interventions for young children are predictive of progress that a child's developmental course is going to make. There's a growing recognition that maternal well-being is really key, and that is we've probably not been enough attention to prenatal, perinatal, and even postnatal maternal well-being. We are beginning the process of screening for maternal depression. That does challenge us for what are the supports that we bring when there's a recognition of maternal depression. And often maternal depression is code for trauma or trauma histories, ever more than the challenge of how does one bring relational supports and social supports around new mothers who are challenged in terms of building hope, recovery, and resiliency in face of trauma or adversity. This will be our next tall order. How do we bring relational and social supports around families, especially young mothers, such that their well-being can be strengthening than their experience of their care of their babies as we move forward. So when we talk about maternal well-being, we're talking about postpartum depression screening, primary care, and other sectors. We're talking about integrating behavioral health and dyadic therapies if possible, recognizing that there are limited resources and capacities in so many communities. We're learning that the power of community and peer supports can be very strong in terms of helping maternal well-being strengthen. We know that our efforts around home visiting have been important. There's increasing maternal cultural and public attention to maternal mortality and the disparities that are directly related to this. These are growing opportunities for us. The CDC and ACOG are increasingly focused on the sense of the fourth trimester supporting maternal well-being after birth. And there's increasing movement around community health workers, peer supports, and even doulas as a part of building wraparound activities to strengthen the relational supports around young mothers, which of course translates to the benefit of their young children. And we know that the context of place-based work that all of you are involved in matters, and the alignment of teams, of vision, of goals, of networks, all towards a concept of collective impact, or even bigger, becomes us in terms of even bigger, like building the well-being of all next generation young children, is the tall order of our work in front of us, and it becomes really essential. All that we're seeing about success in building human capacity requires the sense of nurturing care that has been well described now through so much of the research across the last 2 decades, now incorporated into the Sustainable Development Goals thinking that has to be thought of as nurturing care, supporting the health, nutrition, safety and security, and responsive caregiving, as well as early education. We like to say that strong relational supports build the foundation for health and early learning. And that primacy of the relationships is really growing. And the focus upon the mitigating role that relationships play, the importance of a focus on strengthening all relational experiences around young children, young babies, is the way that we not only build capacity, but protect against trauma, adversity, thereby, as we say, mitigating adversity of the strength of the healing capacity of relationships. I'd like to propose to you that that's naturalistic in human development. I think it's increasingly primacy of the way we think about building human capacity is this focus on early relational health. I'm often asked, what's the definition? And we're beginning with a concept that is complex, and we're working and we're about to begin a analysis with our friends at the Frameworks Institute to really help us think through the key concepts embedded in this concept of relational health. But by definition, early relational health is multidimensional. It's a dyadic construct established by all caregiver-child interactions during the first 1,000 days of life that build lifelong health, early learning, social emotional capacities, self-regulation, and resiliency. It is this relational context within which the brain and physiology and health and stress systems are built in the next generation. In that way, it is part of physical health development, developmental health development, but increasingly we're seeing that the relational context, the early relational health, drives the development of health and cognitive and learning capacities. This increasing emphasis on the relational context is really key. And of course, we're talking about attachment. We're talking about the strong serve and return efforts, the attunement, the positive affect, and the engagement that all caregivers find in the delight they experience in the interactions with the next generation. Babies are sponges for absorbing the positive affect and relational interactions of all people, which is part of what naturalistically builds their abilities and social well-being and human capacities. So when we talk about early relational health, it really is a broad overarching term that subsumes and builds on what we've learned from the field of infant mental health over the last decades. And it elevates the concept of promotion, prevention, surveillance, monitoring into all the systems that are surrounding young caregivers and parents, be that young caregivers and babies, be that parents, mothers and fathers, aunties, uncles, other caregivers, but also all the caregiving systems, be that childcare, friends, childcare of all levels. And in the continuum of early relational health goes from promotion as universal to targeted and specific of relational interventions that have been increasingly described and have an evidence base that's building. This whole continuum of early relational health to treatment and intervention is before us. And yet we know that our workforce for treating challenges of children with infant mental health challenges or relational challenges, our workforce is thin. We know that we're not going to treat our way out of this epidemic of weak social emotional development. We know that we need to elevate the supports and the attention to the relational context for all infants and young children at a population level in all communities. And we know that this is cross socioeconomics levels, and that all parents are wondering and thinking about how do they show the delight and build the capacities as they would wish for the best outcomes for their children over time. So this is first a concept, and that is it is not just about mothers and babies and attachment and bonding. It really is about the attention that all caregivers bring to the delight and their promotion experiences and activities with young children, be that fathers, extended families, childcare providers, siblings, and peers are all relationally a part of this work. And those of you that know Bruce Perry talks about the shift culturally of the number of number of relational experiences, and that sense of the decreased the numbers of social interactions available in the earliest years of building the next generation. That creates the challenges that we're trying to note, and hence why the importance of early relational health as a construct in all that we do becomes increasingly valuable. The concept of early relational health also is meant to be respectful about multiculturalism and to value all the variations of culturally based early childhood practices. It's not just about parenting, but it really is about the frame of building family relationship efforts. It's about relationship building, not just teaching parents. It's meant to be strength-based, not about finding another quality that parents have that they could fail at. This is intentionally to focus on the natural relational developmental patterns that are inherent in human development, the discovery of the dance and the joy that is bidirectional between infants and caregivers that needs time and attention. It's compatible with the concepts of brief, high-quality moments of relational interactions that are being elevated in early care and education and infant and toddler childcare, and also that sense that we only need good enough relationship experiences, but we have to have a number of them. in order to help build well-being. And hence, this concept also provides exploratory opportunities across the sectors of policies, communities, professionals, and caregivers in front of us at this time. The science is compelling. Increasingly, there's a growing scientific community focused on synchrony, dyadic neurodevelopment. When one looks at how dyadic neurodevelopment influences and is observable at multiple levels of human interaction, we see synchrony from the biological space to behavioral synchrony to the stress regulation systems that synchronize between caregivers and parents in a physiological dance of heart rate coupling and synchrony that is really the foundations of building stress and stress regulation and ultimately executive function. We also know that there's a synchrony of endocrine systems such that we see the development of diurnal cortisol patterns, as well as other neurohormones that become entrained, as the words go, between a caregiver and a child. Hence, the first 1,000 days, it may be even the first 500 days, continues the biological development that moves from one generation through the relational patterns to the next in building their strength and physiology. That's all included in this concept of early relational health and the patterns that move forward in order to be able to do so. And the research is going to continue to build in that way to help us see the foundations of building health, development, and brain health will be relational. I'm going to show you 3 quick videos. Now, unfortunately, the sound is not available to you. You will only see nonverbal. But I'll propose to you that most of the early stages of human development, although language is critically important, there's a richness of nonverbal interactions that one can witness. So I'm going to show you 3 sequences and describe a little bit of what I see and relish in the dyadic interaction. Think about affect. Think about the dance. Think about the imitative serve and return affective state that you're witnessing right in front of you. So here's the first. This little boy and his mom, he is 13 months old. Watch this cute little dance between them, a little tussle. He wasn't very happy at her making him hold that item. He grabs his own, he looks at her, he imitates her, he sees his face light up, and then he disconnects, as they all do, and then he re-engages, smiles again, and then dad can't stand but want to be involved too. We would say that this is a really, demonstrates to you a strong relational pattern. You see the affect, you see imitation, you see each member of the team of the dyad or the triad engaging with each other and being a part of the effort. That's a dance that's observable and important. If we look at another dyad, similarly, of a different style, I'm sorry. Well, you will not hear this, but watch what you see and think about the variations of this interactive dance compared to the first. First of all, I'm sure you're all waiting to see some level of interaction. It's not there yet. Even if you could hear it, there's little voice, there's not much said, there's not much engagement. Where's the dance? So as you watch this little pattern, you find yourself wondering. That could be another view of the relational health pattern that might generate a desire to know more and to explore more. In a third sense, another pattern of interaction. Again, you can't hear this, but unfortunately, this mom is talking constantly. And he's not really imitating with her. She's trying to engage him wonderfully, and she's moving very quickly, and he's struggling to keep up. You could find yourself again wondering about what's the story here, and how can you strengthen this relational health pattern that's witnessing right in front of you. That's what's striking for me is that in such a short time, you're observing patterns of interaction. And those of you that watch any level of caregivers and young children, you're observing a pattern of interaction and of skills and of sets that have you immediately begin to assess what are your thoughts and also make some decisions about its health, its vulnerability, or the need to do some kind of work. That's all within the concept of strengthening the relational context. We know from the science that there is definable, observable skills and observable patterns at each over the earliest months that can be documented and can be demonstrated. We know that they build sequentially in a beautiful dance over time that have been described by the late Stan Greenspan and others as a part of the social emotional developmental pattern that's observable in a sequence of time. When one's intentional to look at the interactive space, you can see solid developmental patterns, or you can see challenges that are dyadically based, either from the child's own capacities or the context of their experience with others, or from the parents awakening and engaging and supporting the developmental pattern. But between them, you're looking at dyadic health in the relational context over time. That's, again, built into this concept of work. And then, hence, we're talking about early relational health as being dyadic, observable, and two-generational. It's meant to be bidirectional, as looking at the caregiver child development and the centrality of affect, because we know from the work of Stan Greenspan and others that affect, positive affect, drives human development, or its absence, one sees the wilting of human development. Hence, affect is a strong driver of relational health. We also know that relational health is foundational to issues related to equity, resiliency, recovery, and protection. The mitigation and the careful attention to build solid relationships explains some of the variations we see in face of adversity, where we still see a significant percentage of young children that do well despite contexts and environments that are challenging. Much of that is due to the relational context and the resiliency built into the relational growth and development. So we say early relational health drives the competencies of health, early learning, and social emotional development. It's science-based, it's strength-based, it's family-centric, and it recognizes cultural variations, and hence it's really a paradigm shift in early childhood and society and for our culture. But from the concept, what are the actions? What do we do? And I'm suggesting to you that there's already a movement in the early childhood system space to broaden early relational health into action. The Reach Out and Read program is relationally focused. They're increasingly focused on promoting relational health in their ongoing work in primary care practices. The curriculum that is promoting first relationships in pediatrics, housed in built out of Seattle, is important in terms of building relational context and how pediatricians can focus their efforts on conversations and promotion of relational text. We know Alan Mendelssohn's work about the Video Interaction Project was an evidence-based, using video feedback with parents to promote well-being is gaining an ascendancy and is evidence-based. There's work going on with a relational health screen approach using video feedback in primary care as a promotion strategy. Martha Welch has developed the Emotional Connectedness Scale, which is a short video screening effort that can look at the emotional connectedness in primary care, and that's being studied in some piloting work. The Filming Interactions of Nurturing Development by Phil Fisher, likewise, is another approach, and certainly the foundational work of Healthy Steps and DULCE, working within the platform of primary care to focus on promoting not only social determinants of health, which would thereby impact relational health, but even more intentionally focus on the relational health context within Healthy Steps. These are all gaining an ascendancy as being relational health efforts in practice. My colleague, Kate Rosenblum in Michigan, has been working in medical homes, advancing the use of video feedback in primary care. Strikingly, within the medical home, using a video-based invitation to make a movie with families as they come in for their well child visit has been delightful in showing an uptake of over 70% of families that are offered coming in early for a well child visit will do so in order to have video feedback about the strength of the relational health and promotion efforts that can be brought forward, which I think it continues to tell us that families are really seeking this kind of information. But what about in communities? First of all, evidence-based home visiting is all about promoting relational health. And even at the most recent forum or symposium on home visiting, one of the call-outs of the next level of both research and policy is to promote relational health through video feedback in home visiting. Home visiting being directly focused to Gen, and in the home, focused on strengthening and promoting the relational health experiences. I'm also aware that there's some work moving by Dr. Lee out of Harvard about Department of Education focused on high quality moments of interactions, early care and education, using actually video feedback within childcare environments focused on those about promoting and strengthening the relational moments as a part of promoting, I would argue, relational health in the effort. The Bridgeport Prospers work that's going on is really a whole community focused effort of activating parents, grandparents, childcare, health system, and public messaging about for all babies, all focused about the first 1,000 days and strengthen the relational context. It's an all-in community effort. And I am aware of my colleagues in Oregon who've been working on engaging peer support around peer support of recovered mothers and women in neighborhoods to support new moms who are struggling with opioid use disorder in a peer support focused area, focused on the relational health and maternal well-being for them and then their babies moving forward. So if we think about early relational health into the future, there are many opportunities of really focusing intently on the relational context, be that from home visiting or a redesigned pediatric medical home, advanced medical home effort, the work towards strengthening every relational context and activity within early care and education, and child welfare in their work in supporting foster families and the recovery of families from vulnerabilities and challenges of at risk for maltreatment, or places where focus on strengthening relationships, maybe healing and advancing well-being. This will have population-based impacts on not only disparities, but also kindergarten readiness, and it calls out what we think will become a preventative mental health focus, breaking the generational transmission by a focus on prevention, promotion, by healing relational patterns, and hopefully that may give rise to bending the cost curve. The broader cultural context about countering the hyper-individualism, the crisis of connection, and the fragmentation may challenge us to really think relationally from the earliest start. And even in the last 2 weeks, I saw increasing research surprising me about the importance of child's later competencies related to the kind of toys and interactions they have. And some research that looked at object-directed play with toys is more stimulating of cognitive and communication development, whereas person-directed interactions really drive social emotional development. And I think of this as being very supportive of the importance of continuing to focus on relational context and early development. So to finish up, this early relational health is really about advancing a model that builds social emotional competence in childhood and society through attention to positive family-child interactions, that is social competence. It really is intentionally focused on strengthening the relationship the first 1,000 days. It's as if once you move into a dyadic and relational health view, you can't go back. You can't think about infant development without thinking about all relational experiences. You can't look at the development of a child's skills without knowing the relational context of their work. But relational health is not about one program. It's about an all-in approach across all place-based community efforts in young families, thereby calling out the maternal well-being, the relational patterns, and all in focus on the interactive and positive stimulation interactions with young children and infants. And it expands the sense of social capital in the community to support all families. It's strength-based and builds resiliency, and is a part of a recovery movement beyond trauma and adversity. It's not about teaching parenting. It's really about developing healthy relationships, which is dyadically based. We all know that infants shape parents and help them develop. Often, strong relational supports around young mothers and babies helps mothers heal and build the competencies and practice they need to support the growth of their own babies and development. And hence, it's a mind shift towards a relational focus rather than a focus on the individual. So I'm delighted to be able to have this conversation with you. I think I'll get to see some of you in the gathering coming forth next week in DC with some of the community-based work of NCIT and EC Links. I welcome discussions and questions now. And of course, I'll be at the meetings next week and happy to meet further with all of you about any thoughts, reactions, counterpoints, or opportunities that you see in front of us. Thanks so much. Ngazi?
Dr. Willis, yes, thank you so much for your presentation, Dr. Willis. I think many of our listeners are thinking about the power of relationships and ways to enhance relational health with your presentation among babies and caregivers. So thank you for that. And now we'd like to open up the line for questions. So just as a reminder, if you've joined us late, if you want to put forward a question or you have any reactions to the presentation, we encourage you to either raise your hand so that we can unmute you and you can ask your question directly to Dr. Willis, or you can type in your question in the chat box. So while questions are being formulated, there is a question that's come in the chat box, Dr. Willis, so I just want to pitch it to you. So the summary of the question is, so this is from a fellow pediatrician, and this person is suggesting that he or she has seen some hesitation among pediatricians to embrace the concept of early relational health and believe that the barriers might be time, money, and or lack of knowledge. So the question is, have you encountered this, and do you have any suggestions on how it can be overcome?
Thank you. Absolutely. This is a pediatric practice, and it's the challenges of its time, the number of families we have to see, the lack of support and resources continues to be a challenge for all of us. Trying to elevate the concept of relational health is intentionally trying to make visible for policy and for financing structures to support advancing some of the transformational activities of the medical home. That said, that is slow at times in progress and challenging to finance and sustain. I have certainly called out the opportunities of reach out and read. In other words, practice activities at present that could be brought into primary care that are focused intentionally relationally, be that reach out and read, which is focused on the relationship to promote positive relational experiences around book reading and the like, which is intentionally relationally health focused. I called out the training processes around promoting first relationships as a mindset, pediatricians' roles in thinking about how they promote relational patterns. As we start to co-locate behavioral health services within the medical home, and some practices have begun to be able to do that, then any of the kind of screening processes we do around social determinants could be intentionally focused upon strengthening the communication with families about how any of the challenges of adversity or food or the like actually disrupts their thoughts about their desires for the kind of parents that they wish to be with families. I'm aware of the practices that are beginning to do ACE screening in primary care, are discovering that it changes the nature of the dialogue with families about how do we counter the historical trauma that I experienced as a parent, so that I can continue to make certain that the way that I'm working with my new baby is not disrupted by my previous history of trauma. And the nature of the conversation that the pediatrician is having with the families that are within their practices becomes to be more focused on the relational health element. The last thing I would say is there is movement now that we're witnessing, not only in policy discussions, but also in practice with Project DULCE or with the Healthy Steps model, which is bringing a person into the medical home, what is increasingly being thought of as the advanced medical home, for intentionally being team-based care around then providing the supports for first all families, and then second, beginning to tier our delivery system based upon what families' risks and needs are. So I think there's a continuum of opportunities that are growing. But until we as pediatricians call out the importance of our focus on strengthening relationships at every turn, then I think the mindset challenge could be an interferer to the transformations that are really critical in front of us. So it's a long answer to a complicated problem, but the fact that we're elevating this concept as being a part of primary care and community work, and because pediatrics is an access point for all families, and because we're moving around ACE screening, maternal depression screening, and about social determinant screening, all of that means that we've got to be thinking about the supports around us in the communities, or that we can bring into the medical home as child health practice is transforming. So that's not necessarily a satisfying answer, but it's part of the movement that's moving around us at policy, educational, and innovation space.
Thank you, Dr. Willis. So we have a hand raised, and sorry, we've got lots of questions, which is terrific, but we're going to do this in order and make sure that we get to everybody in the right sequence. So the next question is in from Dominic Charlotte Swiley, or Swilly. Please accept my apologies if I've butchered your name, but
No, that's quite all right. Thank you so much. So I am calling from the DC area, and we have begun looking at early relational health conversations with our families and understanding that. I wanted to pose the question to Dr. Willis regarding, and we have adopted the notion of making a movie with our families in the pediatric primary care setting. So my question is, we've had much discussion within our network regarding performance anxieties and families, really just their concern, or if they're showing up in a way that is appropriate developmentally. So can you speak to the whole notion of early relational health and the videotaping process regarding performance anxieties for our families who historically have been underestimated, undervalued, and marginalized?
It's a very, very important question, and I think central to the message of trying to be strength-based, and also reassuring in the way that we come forth in partnering with families. Certainly, the concept of videotaping is not meant to find problems, but rather to celebrate the strengths. And however, so much of our health practices have often been viewed by some communities as judgmental, if not certainly not equity-based, if not at times even racist. Hence, some families will come in with a sense of the health system being judgmental, or of the vulnerability that they feel of people not valuing their heartfelt desire for love and care of their young children. I think this is both a mindset issue of the way we as caregivers really make visible our goal of being purely strength-based. I think it's part of a messaging that we want to bring, that all parents have strengths, and it's a process of discovery. And I think that we're of course fighting culture at every level that is judgmental of parents, where we think very much about parenting weaknesses, or even teaching parents what's best about parenting, rather than celebrating the capacities that all families have to discover the joys they can have with their young children. So I do think that this is a real challenge. There's no way, I don't want to minimize this, but I think that more this becomes a
Dr.
universal.
Willis, sorry to interrupt, but I just wanted to let you know we're getting an echo from your side of the phone.
I'm talking the same way that I have been, so I don't know what else to do.
It just went away, so maybe it was just talking about it that did it.
So my comment was, the more this becomes a universal approach with all families, rather than thought of just for those families that are most marginalized or most vulnerable, I think we can begin to counter this. I think it's a real issue that we will have to learn together about how to address this concern.
Okay, I think we may have fixed the problem, but we'll know when we talk some more. So thank you for that, Dr. Willis. The next question that's come in says, I work with high-risk young mothers who we often observe as not or perceive as not having healthy parenting techniques. I understand that early relational health is not parenting, but how do you incorporate early relational health work when parenting interactions do not support, when the parenting interactions do not support relationship building?
Obviously, we're in the center of the work that's been long-term studied in the field of infant mental health, and the sense of partnering and supporting a belief that all parents can discover ways to strengthen their relationships themselves. We believe that video feedback, for example, where parents have the process of self-discovery with the support of someone with them that celebrates the strengths, is part of an intervention strategy that has power. The very fact that we witness weaknesses that are observable in a clinical sense, but that we're trying to build a relationship that's healing with the people that, and strengthening with the people that we're working with, is one of the core principles of being strength-based and being resiliency-based with families. This is complicated work, and I'm not trying to make it in any way simple, but it calls out the importance of knowing a family's history, knowing what their goals are for themselves and for their baby, knowing the challenges that they experience in their own caregiving early, their own desire to create an opportunity for something different for their own baby, the dialogue that can be made, and the effort to connect to other support structures in the community, be that home visiting, or if there in fact is available more intensive relational interventions in the community, is in the same spirit here. So not in any way to suggest that observing a pattern that's struggling, that would be an easy way to make change, but rather to be intentional, to partner with parents in a way for their own goals of discovering ways that can be much more successful. again, if we start with those of greatest challenge, thinking about how do we wrap around our belief of their recovery, resiliency, and discovery, that in the partnership we have with them over time becomes really important.
Thank you, Dr. Willis. We've got another question from Gail Lavelle. She's had her hand raised.
Hi, Gail.
Hello, Dr. Willis.
Hello.
Hi. My question is, how can child care providers help build better relationships with young children? And also, how can they use their centers as a way to help support families when it comes to early relational health?
That's a fabulous question, in the sense that caregivers and certainly child care providers are equally important in creating relationship experiences in the development of young children's capacities. And so the positivity, the excitement, and the joy that child care providers have in their relationships with infants and toddlers becomes really exciting. And thereby honoring the value of early care and education providers in this same effort to create a safe, nurturing, stimulating, and positive relationship in those moments of interaction in child care centers is every bit as important as our focus on strengthening the family context that's likewise trying to build strong relational experiences for young children. So I see that as part of a partnership that parents have and child care providers have towards the same goal and the same ends.
Okay, thank you.
Mm-hmm.
Okay, Dr. Liz, it looks like we might have time for one more question. So this is another pediatrician who's written in and has asked, do you have suggestions about how this important information can reach parents and caregivers in grassroots, from the grassroots perspective, so deep in the community, and so not only for high-risk parents, but how to make the whole community aware of early relational health?
Well, I think that's part of that's a great question. Thank you. The sense of community context, of universal messaging about the criticalness of relationships becomes key. Certainly materials from 0 to 3, materials from the Infant Mental Health Association, materials from Harvard and the like are all talking about the relational context being really important. And all of our place-based work that is really starting to surround communities with the alignment of programs and activities towards an aim of improving well-being collectively could and can create a messaging campaign for all people of similar messages. Take a look at the work of the Bridgeport Promise, or look at the work in Oakland, or look at the work in the Chicago region, where efforts to make visible about human well-being and kindergarten readiness, social emotional development, are embedded messages across all sectors that touch young families becomes really important. There are a lot of resources out there. I think the alignment of networks of community leaders and either the early childhood hubs or the early childhood tables can make resources available from all of the different TA centers in terms of making a campaign strength about supporting relational health development. I think it's a unique opportunity.
Great, thank you. We've got another question that asks, so should we be talking about early relational health and not just infant mental health? How do the two come together? What's the correct terminologies to use when talking about young children and relationships?
I'm not sure I can say correct, because I think that the concepts of early relational health and infant mental health are so embedded as one. I don't see them as different. I have heard, and I'm curious as to how you all think about it, and maybe that will generate conversations among yourselves, about the vulnerability of stigma around infant mental health. And we am conscious, we've all been conscious of the struggle of stigma around mental health and engaging families in supports, whereas we talk about supporting strong relationships, the sense of promoting early relational health, part of what we want to test and learn about is that does that actually engage families and engage communities in greater activities and counters any of the sense of stigma or vulnerability that sometimes is captured in the concept of mental health itself. This is all about discovery and about elevating the importance of relational efforts in every sphere and in all work we do. The last thing I would say is the field of mental health, unfortunately, struggles with expanding the the breadth of capacity needed in order to be able to build supports and interventions. Evermore, why health system and public health and then community supports surrounding promotion prevention efforts that have been built from the knowledge that comes out of the field of infant mental health becomes a unique opportunity. And so the two terms are in synergy and we think beneficial for both. We think that the promotion effort around promoting early relational health may engage more stakeholders, more people, more policy efforts, and more intentionality. So that is to be discovered, and we'll be interested in learning with all of you about how that may occur.
Thank you, Dr. Willis. It looks like we're at the end of our time. We want to thank you so much for your presentation today. We encourage participants that may have other questions or comments to just write us at the end of the webinar. And we also will plan to post this webinar and the slides a couple days after today, so I guess that's Friday. And we'll send a note just so that you're aware that it's gone up. We also ask that you please take the evaluation that will pop up after this webinar so that we can continue to improve content and the experience for you. So thank you all so much, and thank you again, Dr. Willis, for the wonderful presentation, and we hope to be in touch with you soon. Thanks. Bye-bye.
Thanks so much. Bye, everyone.